Good evening and welcome to NRAS Live. My name is Claire. I'm Chief Exec of the National Rheumatoid Arthritis Society, NRAS for short. And I'm delighted to be joined here this evening by my colleague, Elsa Bosworth, who is the founder of the charity, Dr Lindsey Cherry and Nicola Hood. And I'll allow them to introduce themselves to you now. So Lindsey, over to you first.
Hi everybody. I'm Lindsey Cherry, or Linz as everybody calls me. I'm an associate professor at the University of Southampton and a podiatrist with Southampton Central Primary Care Network, and I am a clinical academic podiatrist, so I'm still working in the NHS and have done for many years, whilst also researching with the university.
Thank you, Lindsey. Nicola.
Good evening, my name is Nicola Hood. I'm an orthotist in Hertfordshire. I predominantly work in a couple of local hospitals providing orthotics care. We work very closely with podiatrists as well. And I've worked there for about 11, 12 years now. So yeah, nice to be here, thank you.
Thank you, Nicola. And Elsa. Oh, you're on mute, Elsa.
Somebody had to do it, didn't they? Good evening, everybody. I'm Elsa Bosworth and I'm NRAS's National Patient Champion. And I've had RA for over 43 years. And so I've got plenty of foot and ankle problems. So it's going to be really interesting to hear Lindsey and Nicola tonight. Thank you.
Thank you very much. And just to remind everybody that's viewing, you can submit questions. We may not be able to get to them all. But we have already had some submitted as well. So we will do our best to answer as many as we can. Do please try and keep them as general as possible. Of course, we can't give clinical advice. And if we do ask your question, we will keep it anonymous as well. So please feel free, if you're watching on Facebook, you can put it in the comments. If you're watching on Twitter or LinkedIn, you can do that also there. And so we'll crack on. And I'll hand over to Lindsey, who will first of all kick us off with a short presentation. Over to you, Lindsey.
There we go. Hopefully you'll see my screen share with you shortly. Fantastic. So what I thought I'd kick us off with was really an overview of who is involved in the foot health team, because it's one of those areas that I know most of us get a lot of questions about all of the time. Where can I get help from? Who should I be accessing? Who are all these different people that can provide us with some advice and guidance around foot health? So I've put this particular document up here because this was published by Health Education England, as it was, now supported by NHS England, NHSE. And this is a document that was published very recently in the past year or so that sets out the standards for the foot health workforce. The link is here as well, but if you Google standards for the foot health workforce, you'll find this document. And contained within here, there's some guidance around the different roles that you'll find, the level of training and qualification that each of those roles have. And then I've included here, now excuse this, this is a diagram from this document, and I understand that it's not easily digestible on first glance. So I've put to the right of it here the summary of what this picture is telling us. So within this foot health framework, what we've got set out are these 7 different levels of practitioner in relation to foot health care that are now available and provided, primarily focusing on England, but there are similarities across the UK. Every level is really important and has a really critical and valuable role to play in terms of foot health care. It's just that as you move up the levels, you may find that people will go on to do additional training and they get additional qualification and accreditation or recognition for that level of training and expertise. So at the lowest entry level, we have what's called a foot care assistant. Typically, you might find foot care assistants working within the NHS, providing some regular care. So they might provide assistance with nail care, for example, for people that have got a treatment plan in place, who've already been assessed by a podiatrist for their kind of level of general health or foot health risk. As you move up, the 3 levels that you can see here in green are what we call non-registered healthcare professionals. So they have a role to play, but once you complete a degree, you become a podiatrist, and at that point you become registered with the Healthcare Professions Council, and at that point we have a degree of legal and professional responsibility around our level of training and qualification, and it also means that we have to report that on a regular basis to demonstrate the level of ongoing training that we have. One level up from that is the specialist podiatrist. And here is where you might start to find podiatrists specialising in rheumatology. So they have a general graduate level of qualification, but 1 or 2 years after qualification, they'll start to specialise in different areas. And here you'll start to see people specialising in rheumatology. And then it goes on to advanced and consultant podiatrist. To give you an idea of the size of our workforce, there are around 10,000 podiatrists working across England. And we're not quite sure, but I would guesstimate around 20 to 30 consultant podiatrists. So it's an incredibly small pool by the time you've gone through these different levels. So broadly speaking, these are all of the people that could have a really important role to play in your foot health, and all of them will have different skills, but will have different levels of training and qualification. So when you're looking for people, all of these levels in different areas you might find within your NHS. Increasingly, you might find new roles attached to your GP practice. Those will be around podiatrist, enhanced or advanced levels, so those 3 blue levels. And we're seeing emerging. So hopefully that gives you a little bit of help just to navigate and become familiar with all of these different roles and what they mean. So I'll stop sharing my screen there. There we go.
Thank you, Lindsay. I mean, that was quite an eye-opener. I hadn't realised there was quite so many different levels, and I think for your average person, they might not have realised who they might be seeing. So that was incredibly helpful. Thank you very much. So we'll go straight in. We're going to be doing the questions at the end because some of the questions that may have been submitted may be answered in some of these presentations. So I will go straight over to Nicola. So Nicola, over to you.
Thank you. So hopefully you can see my screen now. Excellent.
We can indeed. Thank you, Nicola.
Thank you. So hopefully you guys are familiar somewhat with orthotics, and hopefully if you're not, by the end of it we can familiarise you with orthotics, and hopefully you can be involved to some degree in orthotic services. First of all, what is orthotics? We want to cover that tonight. We want to cover the importance of orthotic intervention, conditions that may require orthotic footwear, what's actually available out there, and then most importantly, how can I see an orthotist? So what is an orthosis? Is a word that we use. You might hear it called splints or braces, but it's basically an externally applied device. And what we try to do with each orthosis is reduce pain, prevent deformity, or improve function, or all of the above. In order to provide orthoses, you will see an orthotist. So we are registered healthcare professionals, and we specialise in biomechanical assessment of the whole body. And we do a lot of work on the foot and ankle, but we do deal with the whole body. And we prescribe, measure, fit, or review an orthosis. Now, interestingly, Lindsey mentioned that in the UK there's around 10,000 registered podiatrists. If you compare that to orthotics, there's about 350 of us in the UK. So there's not many of us around. So the degree, interestingly, is prosthetics and orthotics. So when we do the degree, then people often split, which is why there's only around 350 of us in the UK. So we deal with lots and lots of different conditions. Rheumatoid arthritis is obviously what we're going to be speaking about tonight, but we see a whole host of various different conditions that need orthotic intervention, and a lot of these are related to the foot and ankle and present very similarly, even though they have very different diagnosis. So if you have never seen an orthotist before, when should you think about seeing an orthotist? So ideally, if you're getting any foot pain at all, if you're finding footwear shopping very difficult or footwear fitting very difficult, very commonly we get painful toes. If there's any change in shape or deformity, I always advise people to, we provide a non-surgical option. So quite often a lot of our patients will be offered surgery on these things, perhaps toes that are misbehaving or have moved in shape. And if you come and see us, I like to think that we can provide you with a non-surgical option, perhaps before you go down the route of a surgical option. It's always worth just knowing what all your options are. Quite often, knee pain is one of the biggest things as well. If a patient comes to see me with knee pain, the first thing I'll look at is their feet. So generally the feet are the main offenders, but it might only present as knee pain. So it is worth getting those feet checked out as well. So if you experience any of these above, then it's worth asking to be referred on to see an orthotist. So rheumatoid arthritis in the foot and ankle in particular is a huge issue. More than 90% of people with rheumatoid arthritis will experience issues with the foot and ankle. Quite often it presents in both feet, so we call that bilaterally, and quite often it's in the same joint. So people will often describe walking on pebbles, walking on marbles, burning sensations, issues with their toes or bunions. Those are the kind of things that we see day in, day out. So we've got lots of different options that we can look at. Insoles quite often is our first protocol. There's a huge range of different insoles that we can use. We can custom make them, or they can come off the shelf ready-made. Just depends on the patient's needs. We can use insoles on their own in your own footwear, or we can use them within orthopedic footwear. Most commonly with rheumatoid arthritis, we use them to offload or cushion those tender areas, so particularly across the ball of the foot, for example. And there's lots of different materials and options that we've got depending on what the needs are of the patient. So I said that we can use insoles inside orthopedic footwear, but when should we actually prescribe orthopedic footwear? So when you simply cannot buy footwear in the high street is when we want to have a look at orthopedic footwear. If you have what we call a proportional deformity, so perhaps the front of your foot is much wider than the back of your foot, your heel, due to the rheumatoid changes, then that warrants orthopedic footwear. If we have deformities of the toes, and again, they're really rubbing on the tops of toes, or we're squishing them into the front of shoes, then we can have a look at footwear. Sometimes the insoles we make up, because we've got tons of cushioning in there to try and provide you with some comfort, we then simply cannot get your foot into the shoe as well. And we need to make shoes that are a little bit roomier. Also, sometimes when an increased level of support is required to control the foot and ankle, then we need to have a look at providing orthopedic footwear as well. Like I said, if we're getting that knee pain, for example, quite often if that foot is collapsing in the way, then we need to increase the support of the foot and ankle, and that has a knock-on effect further up the chain at the knee as well. I think most people, when we say orthopedic footwear, they have an image in their head, and hopefully I can try and improve that image in your head this evening. There's a little QR code there that takes us to our footwear catalogue. I'll put it on at the end of the slides again, so you can have a look at it if you've not had a chance to. But basically, this is what our catalogue looks like. And this is a catalogue that was worked on a couple of years ago. So I hope you'll agree that styles, materials, colours, choices have got significantly better over the years. I think, to be fair, they had to, because they were a bit behind the times, but we've got there now. So this is an example of the types of footwear and colour combinations and styles that we offer. Generally, when we are prescribing footwear, we will have a discussion, and there are different styles that will suit different foot types or issues. So we'll guide you to what might work best for you. But there's lots of choice, and if you're completely custom made, so if you want green with pink polka dots, then you shall have green with pink polka dots. Why should we bother with orthotic intervention? A lot of people are concerned about the money that they cost, the footwear costs. They've done research and they repeated the same research, and it shows that for every £1 I spend, we actually save the NHS 4. So you should never worry about the cost of the footwear or the insoles, because we know that it's saving money on other aspects, wound management, if there's infections and things like that. So we're saving money in the long run. NHS annual orthotic spend is around £100 million, and about 10% of this overall spend is on footwear. So a significant proportion of what we do is footwear. It's really important that we see you as early as we possibly can. Early intervention can result in the prevention of wounds, and if we catch you a little bit later down the line, then hopefully we can help facilitate healing those wounds as well. And we can also do our best to slow down the rate of progression of deformity at the very least. So it is important that we see you as soon as we possibly can. Okay, the important bit, how can I see an orthotist? There's only 350 of you in the UK. How can I see you? The best way, and I think this is sort of uniform across most trusts, regardless of where you're based, is to request a referral from your GP, the consultant you're under, or in some occasions your rheumatoid nurse will be able to send a referral over to our department as well. You will find an orthotist in all larger hospitals and most community hospitals at some point across the week. Like I said, there's not many of us, but we generally will be there at some point in the week and travel around various different clinics. So if you would like to see an orthotist, or you feel you need to see an orthotist, either speak to your GP, your consultant, or your rheumatology nurse, and hopefully they can get that facilitated for you. And there's a little QR code if you want to have a quick peek at the footwear catalogue. Thank you very much.
That's great. Thank you very much, Nicola. That was interesting. I've just got one quick question. So it's not possible to self-refer to an orthotist at all, is it? Or if
Certainly
anybody
not.
wants to privately, perhaps?
Yeah, not in any of the trusts I work in. I've worked across many different trusts, and no, it's not possible to self-refer. I think that's probably a budgetary issue. So yeah, it has to be done generally via GP or consultant.
And I should have said at the top of the event, I'm so pleased that you've been able to join us this evening, Nicola, because Nicola's just had a baby 3 weeks ago. So the little chap made an appearance a little bit sooner than anticipated. So I'm really pleased that you were able to join us, and we will fully understand if you suddenly disappear. We'll know why.
Eye bags and all, thank you.
Right. So before we go into our question and answer session, I wanted to go over to Elsa, because Elsa has, as I said, lived experience of many foot issues and has some information to share with us about some survey that was done some time ago.
Can I just ask, first of all, for some clarification, Lindsey, because we used to talk about, or maybe still do, talk about chiropodists, particularly in the community. Where do they fit on your list of people, or are they calling them all podiatrists?
Good question. Chiropodist as a term doesn't fit. It doesn't feature. It goes back many years and then was used interchangeably. But now anybody who is qualified at degree level will use the term podiatrist. Sometimes they'll say podiatrist / chiropodist because nobody knows what we mean if we say podiatrist,
Right.
and if you say chiropodist, they understand. But that's an explanation. But actually, the term chiropodist doesn't feature in any of the roles as they're set out going forward. Chiropodist is not a protected title, so anybody could decide to call themselves a chiropodist without any training. So to really understand the qualification of the person that you're seeing, it's better to try and ask them what their exact title is, because that will tell you something about their level of training and qualification.
Okay, that's clear. Thank you.
Can I add on to that as well? Actually, the same applies in orthotics. So we were known as surgical appliances for many years. So quite often we will people will refer to us as surgical fitters, or again something along those lines. So again, a lot of people don't know about orthotics or that it exists, but it's because they still use the old terminology. So yeah, we're orthotists and podiatrists now.
Okay. So I've got a few questions, but Claire, just stop me when you want to dive into anything else. So back in 2018, we did a survey on access to foot health and care, and we presented on that at the special interest group at the BSR conference that year. And we had over 600 responses. It was an incredibly well responded to survey because it's such a big issue for people, as you've highlighted. 52% said that they didn't have access to an NHS foot care practitioner. Do you think that the situation post-pandemic is any better? Is it the same in your experience, or has it got worse given the workforce issues that we now have? Lindsey and well, both of you.
Shall I answer? Yeah.
Yeah.
I think that there is still huge regional variation. So in some regions, it feels the same or worse. And then in other regions, it's very much better. The BSR did repeat a national survey of departments, and they asked them to indicate whether there was direct access to podiatry. And there was a massive increase in response. So from a provider perspective, they're reporting that there is access now far more readily available to podiatrists. So from that perspective, it's always worth going back to your rheumatology team and asking for those direct referrals into podiatry. And we also have within NICE guidance now clear recommendation that provision should be made for people with rheumatoid arthritis to be able to access support for their foot health. So those two things are hugely positive and favourable. We've also seen a shift in workforce and funding for various roles to be directly available within GP surgeries. And podiatry is one of those roles that are directly funded. So GP surgeries can directly employ podiatrists now to become part of that frontline team. So you should hopefully also find it increasingly easier to access advice and guidance for foot health immediately at that first point of care without barrier, as a self-referral and within your GP surgery. So either directly within your GP practice or within rheumatology, the signs are saying it should be infinitely easier. Anecdotally on the ground, completely recognise that that's not always the experience that people tell us.
That's really helpful, thank you. And that sort of is sending a signal to me, Claire, that we need to make that clear on our foot health area on the website, I guess, because that does need an update, doesn't it? Nicola, is that the same in orthotics?
I'd like to say so, but unfortunately it's not. No, I think we're still not back to where we were pre-pandemic, sadly. Certainly my clinic lists are just about to begin back to pre-pandemic levels, which is bonkers, really. So yeah, we were just getting back to the same number of patients each day, which has a knock-on effect on the waiting list, of course. So our waiting lists to be seen are definitely much longer than they were previously. And we've been running Saturday clinics and things like that where we can to try and reduce those waiting lists. Orthotics is a very small department, and typically we're not employed by the NHS. We're employed by a private company that's subcontracted to work for the NHS. And so it's often a challenge to get those extra clinics or the extra funding that we need to secure those extra clinics. We're working hard, and hopefully it will start to improve. But yeah, our waiting lists are definitely, they're not wonderful, but we do have a triage system where if you need to see us urgently, then we'll do our best to get you in as urgently as we possibly can.
Okay. And another question for you. One of the themes that came out of that survey in 2018 was that insoles often cause more problems than they solve. And I can certainly say that that's been my experience. I've had 2 occasions over the years where I've had bespoke insoles made that have caused a huge amount of pain when I've started wearing them, and ended up just having to remove them and not wear them. Is that, could you explain perhaps why that is, or what the cause of that is?
I'm really sorry to hear that, for starters. I guess the challenge with custom-made orthotics is that there's no right and wrong answer, and quite often in orthotics, regardless of the presentation and the problem, there's a bit of trial and error, and what works for you might not work for me, and vice versa. And sometimes it does take a couple of different prescriptions to get that quite right. Yeah, unfortunately, I'm really sorry you've had that experience. We'd like to think that that's not the service we're providing. However, what I would say is that if we provide anything at all that doesn't work for you or is uncomfortable, unless you tell us, we'll never know. So it's really important.
I mean, it may be that some of those were just bought off the shelf and weren't bespoke. But the ones I was talking about certainly were. But that may be because I've had substantial foot changes over the years, and I've got a lot of damage in my feet and ankles. And I think when you maybe get an insole, a bespoke insole, when your foot is very rigid, that it takes a while for it to work in and for your foot to become accustomed to it. Would that be fair to say?
Yeah, it can take a while for you to get used to using it. It's going to feel very strange initially. It shouldn't really significantly increase your pain. But like what you said about if there's lots of changes, sometimes we tend to find that we end up just chasing the changes in the end, and that can be problematic for us getting something that works right for you as well. I think what's also worth mentioning is that although I encourage everyone to come to orthotics as a non-surgical option, it's always worth bearing in mind that sometimes we simply can't do what we would like to do with orthotics, and it does require that multidisciplinary team with the podiatrists, with the surgeons as well, in order to get the most optimum result for you. So sometimes if we find that actually orthotics, we simply can't get it right, we maybe need to look a bit further afield to see who else can we involve that might be able to help here.
Okay, thank you.
Question.
I hand back to you to ask, ask something else. I have got some other questions, but we'll the limelight.
I just saw a question pop up from our good friend Teresa. Hello, Teresa, you're watching. About, are all orthotists working in the NHS linked with Halo Medical, or are there others that are out there, or would some have access to different catalogues of footwear?
Yeah. Hi, Teresa. Yeah, that's a good question. No, not all orthotists are linked with Halo Medical. Halo Medical is a company that I work for. There's a few different companies and therefore a few different catalogues that have different styles of footwear. I think probably the Halo catalogue is probably the most recently updated. So I think the styles and designs are a little bit more modern. But no, there are other companies that provide it as well across the UK.
And a question really for Lindsey here, you know, that was submitted pre this evening's live broadcast is, when do you envisage foot health clinics being an integral part of every rheumatology department? And sometimes it's just so hard to get anyone to listen. Where's that ideal world?
It is. I wish I could say I could wave a magic wand and I would see that happening. I don't know when. I'm reluctant to say it won't happen because, well, we're all continuing to push for that because it's so important. And I think there is increasing recognition that foot health, just thinking about foot health, is important. But of course, foot health relates to your ability to be physically active and access the rest of your life, and therefore your cardiovascular health, you know, your circulation, your wider joint health. And I think the more that we're able to keep putting foot health in that bigger perspective, the more we can keep lobbying to show how important foot health is and why it's really important. As a team, we all keep thinking about foot health. So hopefully that's maybe the way, although you maybe don't have the podiatrist there right now, but that's the conversation to keep having with your team to help bringing it in focus with everyone else around you as well.
Indeed.
Can I ask a follow-on question to that, Claire? Again, going back to the survey, when asked if anyone had inquired about their feet at the consultations that they'd had recently, 75% said no, and more than 50% said that no one had ever asked about their feet. Can I ask what kind of conversations that you are having with your own team and your own networks about getting non-specialist, non-foot specialist health professionals to actually ask that question and prioritize foot health a bit more than it appears over the years to have been?
Yeah, really good question. So one of the big barriers we know is that the DAS 28, that score that unlocks medical, you know, that very medicalized summary of how your arthritis is, it just doesn't include your feet. And of course, it's a tool as part of a consultation, but that can be sometimes the wrong focus in the consultation. The way that we kind of talk about it, or the key questions, are really about being able to access the rest of your life. So having various blood markers of inflammation is one thing, but not being able to work as you would like, not being able to fulfill your childcare responsibilities as you would like, and also not being able to feel like yourself or have your identity is really, really important thing to bring into the consultation. There's some lovely work that I would refer people to by a colleague called Anita Williams, where she's talked about the real importance and significance of footwear, which goes back to kind of something that Nicola was saying, that what we wear on our feet, it is part of our identity. It's who we are. It's how we signal to the world. These things really, really matter. So just being able to put context around foot pain or the foot issues is a really useful way to bring it into the consultation and help people understand a bit more for you why it's so important. It's not just about having another pain. It's a really meaningful, significant pain because, and then explaining in that way can be helpful.
Yeah, I think you're absolutely right. I can remember the joy that I had when I had quite a bad valgus drift on my right ankle and my left ankle, which was, you know, over on one side. And for years, I could just wear cloggy things. I couldn't wear shoes because they just gaped and looked awful. And when in one of the ankle replacements I had, he straightened my foot, the surgeon, and I could actually wear a proper trainer, a boot. I got my first pair of long boots, and I was just, you know, beside myself with delight that I could be like everybody else, you know. And you're right, you can't underestimate how horrible it is going to somewhere special, a wedding or something, and having to wear revolting shoes because you got a lovely outfit on and a hat or whatever, and horrible shoes.
Yeah.
It sounds sort of vain, but you're quite right. It's really important to people.
It's really, really important.
Yeah, and I think that's, you know, that's been asked a few times in the questions. You know, are there best brands or types of shoes, off the shelf shoes, or brands that, I know we're not going to be endorsing any particular products, but before you have to get orthotic shoes from the lovely catalogue, but are there probably shoes to avoid rather than shoes that you'd recommend? But are there particular ones? I mean, we hear a lot about hotter shoes. Are they probably better supporting the ankle or anything? I think that's probably for you, Nicola.
Yeah, there's lots of different brands and styles, and can I share my screen again, actually, and I'll cover a couple of them. Is that all right?
Yes, please do.
It's misbehaving. Can you see it? No?
Yeah.
Oh, yeah, there we go. Yeah, so what makes a shoe a good shoe? And I think this applies regardless of any sort of issues that you're having with your feet. Quite honestly, I don't care how much a shoe costs or what brand is on there. If it ticks these 4 boxes, then it's a good starting point. So ideally, we should have a fastening. Ideally, lace or Velcro. That fastening is what holds your heel and your foot into the shoe. As soon as you have a slip-on, you will find that we either rely on those toes to grip to stay on, or we have to be wedged inside that shoe to stay on. So a fastening is really, really important. Excuse me, sorry, my laptop's about to die. Let's not have that. Ideally, you shouldn't be able to twist the sole. So when you pick the shoe up, it shouldn't be soft enough that you can twist it. And quite often people will say, but it's lovely and soft and it's therefore very comfortable. And quite honestly, it's not doing any good by having that. Sorry, we're back. We've got power. We're good. So yeah, it doesn't. We don't want it to be soft and flexible as much as that sounds like we want it to be. It doesn't work for giving us the support. Importantly, when you pick a shoe up, you shouldn't be able to squeeze the back or the sides down. Again, quite a lot of foot deformities will cause that rolling in. So if we've got a back and a side that's not stiff enough or strong enough, it's not going to support that foot. And the last point is we want the middle of the heel thicker than the midsole. So we call this the pitch. So ideally, we don't want a shoe to be very flat. If it is, it will cause other problems. So we want a bit of a difference between just where my red arrows are, a bit of a difference between there. And obviously not too much, because then we start looking at high heels, which we definitely don't want all that, the weight on the front of the foot. What's available on the high street? So you will be able, there's a range of off-the-shelf prefabricated insoles that you'll be able to get online. Again, if you're looking for something specific or in particular, I would recommend a referral to Orthotics. But some brands to have a look at, Easy Bs or DBs, I generally find are slightly wider and deeper than most other brands. Cozy Feet and Hotter are 2 of the probably most commonly known brands. There's also another brand called Billy Footwear and Be Friendly Footwear. So these are specifically designed for use with orthoses. So they're generally, again, that little bit wider and deeper to allow you to accommodate insoles and various other braces and things. So there's lots of brands that are available on the high street. And again, if you're buying your own shoes, then you can decide what colour or style or how many pairs you want. So it gives you a little bit more option and flexibility. But there are different ones available that you could try perhaps while you're waiting on a referral to orthotics, or if you've got that wedding or whatever, then you could maybe try these sort of brands to see if you can find something that might work for you.
Thank you. That's been really helpful.
Sorry, the other thing just to consider is a non-leather upper. Shoes that are not leather will give a little bit easier. Again, those wider and deeper fitting shoes, sometimes just taking the insoles out of shoes will help, and then we can replace it with our insole. And it sounds really daft, but if you consider gents footwear over ladies, a gents size 6, for example, is much bigger than a lady size 6. So it's worth considering that as well. And if you do have any swelling, speak to your GP about getting that managed, because that can impact on footwear fitting significantly.
They were really useful, very useful tips. Just going back to the fastening,
yes.
If it was a strap around your ankle rather than a lace up, or is that, as long as your foot is not moving within the shoe, is that just as good?
Yes.
I'm thinking of sandals perhaps, where they might have an ankle strap rather than slip on.
Yeah, in theory, if we've got something to secure that foot in, then that should be okay. If we think about it, though, that one strap is quite a localized pressure on there. So what we can find that happens is the foot's held nice and securely, but then we get a lovely bit of swelling beyond that, just beyond the strap. Mm-hmm. So ideally, a nice enclosed shoe with the fastening, it spreads a load across the full foot, and it can be more comfortable. But if it works and the strap works and you have no issues, absolutely. As long as it's got a fastening, I won't be too fussy.
Yeah, okay, thank you. Right, we're back. So we've had a few questions, of course, about pain, consistent pain in the feet and ankles. You know, somebody's there just talking on the chat that they just will probably live and die in Skechers. But it's somebody asked a question here. I have consistent pain in my feet and ankles, but I've been told wearing braces for long periods of time is bad for me. Is that true? Lindsay, I think that's probably one for you.
That depends on the presentation. It depends what the brace is doing or what the brace is trying to do. There's no right and wrong answer without seeing this case. But what I would say is a brace generally works like a pair of glasses. If you've got it on, you're getting the benefit of it. If you don't, then you're not. So on the whole, if it pays to wear it most often, it depends what we're trying to do. Unless something is particularly weak, and by wearing this brace, we will allow it to get weaker. That's generally the one time where I'd say that using the brace more than we advise isn't ideal. But for the whole, if you've got it on, you're getting the benefit of it.
Lindsay, anything to add on that?
Yeah, I think so the grey areas where we talk about elasticated ankle supports, and sometimes people refer to those as braces or splints. They're slightly different things, but an elasticated ankle support is something that people can readily buy over the counter. You can get them really easily from the pound shop, for example. It doesn't need to be anything fancy, and they can provide really good support for short periods of time, and sometimes that a slight degree of support, not tight compression. You're not trying to stabilize or squash anything or hold anything, but that tiny little bit of additional support improves something that we call proprioceptive feedback. This is about how your body moves and works in space, and wearing it can start to reduce some pain and aching type symptoms, and we know that it can improve the sensation of stability around the ankle as well. What you'll hear is people say you shouldn't wear those all of the time, and that's because if you're relying upon that elasticated support to do the job of your muscles and tendons, they won't be working as hard, so they'll weaken. So then when you're without that support, it will feel a lot weaker over time. So it can be really helpful, used at the right time in the right way, but it's not something that you'd want to use all day every day, because eventually it will weaken the ankle. The million-dollar question is, well, when's the right time, Lindsay? And that's the really hard thing to judge, and that's where it becomes individual. But there's no harm in playing around. The only caveat to that, and I think we alluded it to earlier, is with that swelling of the legs and ankles. So it's really important. You don't have to go to your GP now. So within pharmacists, they're also providing some advice and guidance to help check circulation in the feet and ankles, and to do fitting of some of these supports as well, to make sure that you're not wearing something constrictive or restrictive that could cause you harm if you're concerned about your circulation. But if you're finding that you're getting swelling in your ankles that's worse towards the end of the day, but better in the morning when you wake up, that's a different type of swelling. And that's something that absolutely you can seek advice and guidance through pharmacy or your practice nurse. And some of these supports can start to be really helpful, and they can help you to understand how to use them in the right way.
Right. We have absolutely loads of questions, so there might be a bit of a fast fire round here, but we'll keep going. So I had an ankle, somebody said I had an ankle fusion operation just over 2 years ago. Post-op, the wound became infected. I'm in an air boot. What footwear would you recommend? So it sounds like they're still in an air boot, and that's over 2 years. That doesn't seem quite right at all.
And I think if they're still in an air boot, they're still in the air boot for a reason. I think if they've had the okay to go into footwear, then that's absolutely fine. And also it'll depend how long they've been in the air boot for as well, if it's just post-op. Quite often if there's an ankle fusion, we take away that movement of the ankle, the natural movement, and we want to try and replicate that with footwear. So we can add some rocker soles and some different adaptations that might replicate that ankle movement that might help. So again, that's worth a referral over to Orthotics and we can have a look. But definitely worth speaking with your clinician as to, is it okay to come out of that air cast boot?
Okay. Elsa, you've no doubt recognised some of this. You're on mute again. You can just come off mute. And how was your experience of having an ankle fusion?
I had a triple arthrodesis, which is the subtalar joint fused, and I had both my ankles replaced. And I was 3 months and an ankle replacement repair. And every time I was 3 months non-weight bearing and in a boot after starting to weight bear after that 3 months for a few weeks, but certainly not longer than that, I would say. And that's really hard because when you've got other things like both elbows replaced, I can't hop around on crutches. It was really a challenging time. And whilst wonderful surgeons, they don't really concern themselves with how you cope not being able to be weight bearing at home after the event. So I had to do a lot of fishing around and research to find things that were going to help me after the event and help me in that period when I couldn't be mobile. But one of the things that actually I was asked by somebody last week was if you've got to have a foot fusion or an ankle replacement, which do you have first? And I might be wrong here, but I seem to remember my surgeon telling me that he would rather do the ankle replacement because I've still got a bit of up-down movement in both ankles. But he said if you have an ankle replacement, you can have a foot fusion afterwards. You can't do it the other way around. Is that right? You're nodding. Okay. So I think that you know, I think when you have got foot deformity and you have got pain, certainly my experience is that you need to seek surgical advice sooner rather than later, because if you leave it till your joint is completely destroyed, the surgeon has got less to work with that is more likely to give you a good outcome. So I would, if anybody's getting extreme pain or is getting foot deformity, in my experience, I would say go get a surgical opinion sooner rather than later. Is that something that you think you would agree with, Lindsay?
Yeah, we know that sooner rather than later, and that partly that's because the better your musculoskeletal health around that. So the more you live with pain and the more it becomes difficult to move, we move less and we decondition. So then you're going into surgery in a less healthy state. So that can be really helpful. And the other thing I would say is reach out, and our physiotherapy colleagues have a really important role to play here. And certainly for the poor person who's been in a boot for 2 years, they'll be moving differently because of it. And you also need some really good physio and support when you come out of a boot or anything like that. If you've been in it for longer than 3 months, physiotherapy is really, really important. Similarly, if you've had pain, we know if we're in pain, we lean forwards. That's our natural response. And if you're leaning forwards, you put a lot of strain through your lower back, your hips work differently, your knees work differently, and you put your weight through your feet differently. So if you've been in pain for a long time, you've probably been walking that way for a long time, and it takes a team of support around you to undo that. So accessing physio as well is really critically important.
Great, thank you, Lindsay. There's a really interesting question here. How do I slow down all the toes on my right foot, gradually moving to the right and beginning to overlap owing to the RA? Any suggestions would be appreciated.
Great question. If only we had the miracle cure. There's a couple of things that we know from evidence can be helpful. One is keeping on top of inflammation, and you can have low levels of inflammation in the beginning of those toes, the metatarsophalangeal joints there at the base of your toe, even though the rest of your disease activity score could suggest that it's well maintained. So focusing on that is important. There are things called bursa, which are our body's little airbags, and they sit between those toes. So if you've got little bump-like swellings, you can't quite see my hand, underneath your foot between the toes, they can cause the appearance of the toes to be drifting. If you've got those, point it out to your rheumatology team. They need some advice and guidance and treatment for that specifically. So don't accept that as a normal part of your foot being affected by rheumatoid arthritis. And then this is where I'd hand over to Nicola, because we also know that supporting your foot in the simplest form, having a bit of arch support, not a lot, but lifting your foot up and over helps to stop it from collapsing inwards, which forces the toes outwards.
Yeah, absolutely. So really crudely, if my foot's rolling in the way, my toes are coming out the way. So if we can try and prevent that collapse in the way, then we take that force off of the toes that can be contributing to them drifting round. So yeah, it is really important that we get the right support there as well, that has a knock-on impact on everything else.
Lovely, thank you. And this is a good time to mention that we do have on our website, it was recorded many years ago, where with colleagues down on the south coast there, a course that they provided to their rheumatology patients about foot care and looking after your foot and how to examine your foot and because we don't look at our feet very often, you know, but actually when you have something like RA, watching your feet to see those slight changes is really important. So my colleague will put a link into the various different chats if you're watching this, but it's our foot health online course, and that shows you how to look, what are you really looking for, because of course prevention is always better than cure. So if you can catch these things earlier, that's fair. And about foot care as well, it's not just about the joints moving, but somebody's asked a question here. Is RA related to hard skin and corns on the feet and toes, and where to seek help for reoccurring painful bunion? Who wants to take that one? Lindsay, I guess.
Shall I take? Yeah, so this being question. Yes and no. is hard skin. We know that generally people with rheumatoid arthritis experience a lot of hard skin under the ball of the foot, sometimes around the heel. There is, to some degree, if you've got lots of inflammation, it speeds up skin turnover, but really it's because of too much pressure. So the walking really heavily on certain areas of the foot essentially squashes dead skin cells onto your foot rather than allowing them to shed away, and that's all that callus is. It's skin that would have shed away normally, but because we're walking heavily on those areas, it's squashing the skin and it's making it form that callus. And because of how arthritis affects the way that we can walk, it means that we squash the skin on those areas more commonly. How to access help? I refer you back to the foot health standards, and actually that's where it may not be a podiatrist that you access, but it might be some of those other foot health professionals that become part of your foot care team that can give you support with nail care and skin care. You might want to have advice and guidance from a podiatrist. Perhaps they'll put a care plan in place, but there's no reason that you couldn't access that wider team for support. And all of a sudden you find actually there's lots of support out there when you know those particular terms and who to start looking for. I don't know if that answered the question.
Indeed it has, thank you. Elsa, I'll come back to you. You did said you had a few more questions for the last few minutes of this chat.
Well, one of the things that I have, which I suspect may be relatively common for people like me who've had the disease a long time and have got changes in their feet, where you get the metatarsal heads sort of coming down into the ball of the foot. On one foot, I've got that sort of spongy bit of fatty sort of bit that you can squeeze has gone, and so I've literally got bone on skin, and I have to go to a podiatrist every 6 months, every 6 weeks or so to have a corn removed. And I am slightly concerned that I've had this going on for years. If that got infected and I've got metalwork in my foot, is that, that could be a major problem. Is that likely? And is that quite common? And is there anything else I can do other than go and get it dealt with every 6 or 7 weeks or so?
I think that corn suggests we've got an area of high pressure, and we know that the bones, the metatarsal heads, should be covered with that fibro-fatty pad.
Yeah.
And often in rheumatoid patients, it's not. So I would suggest that offloading that area could hopefully help. And it might be that you still have to see the podiatrist, but it might be that you can go a little bit longer between periods of seeing the podiatrist, just by having that area offloaded or cushioned, then that might help. So I think
I do use sort of what's it called, fleecy web.
We tend not to use fleecy web. We tend to use lots of sort of almost sort of memory foam type materials in the insoles, so that they don't bottom out. Fleecy web and things like that won't last very long. Or if your feet are hot or sweaty, then that'll affect that as well. So we tend to use materials that last a little bit longer. But yeah, we want to try and offload that area and to see if we can try and reduce the rate that builds up at.
Okay.
Is that fair, Lindsey?
That's why lots of people just absolutely love Skechers, because Skechers have got that memory pore on the memory foam material inherent within them, and it's lovely. It compresses it a certain way, so it helps to reduce that. It's replacing the fatty padding to some degree that you
obviously
lost.
need to
So
go
lots of people would already love it.
Yeah.
So Skechers are great, but they don't have some of those other key important properties of shoes, although they have brought out now this arch fit range. So and absolutely Skechers are brilliant, and lots of patients will tell me they love their semi-compressed felt pads because they do work. They're just sticking something to the skin is not the best long-term solution, but sometimes we work with what we've got, and if that's what works, that's what works. In between time, still really encourage people, if you can reach your foot, put a cream that's got a little bit of urea in on, because it really does help to keep the skin nice and pliable and reduces the callus a little bit, so it will prevent the risk of deterioration. And then it does make it hugely easier for us as podiatrists when we come to take that hard skin away. If somebody's been using a cream, it's so much easier, and you're less likely then to have a cut or a slip or something that breaks down into a wound. So really helps if you can use those creams with urea between appointments as well.
Are there any
sorry, why do our arches collapse? Because everybody who's had it for a longish time seems to have this problem.
Yeah, there's a common kind of pattern of changes that happen as some of the ligaments and tendons change, and as the joints become inflamed with RA. Imagine inside of them you get all that swelling, and it pushes the joints apart a little bit, and all those soft tissue structures get stretched, and the inflammation goes down, but then that stretching, it doesn't all ping back as tightly as it once was, so then it all kind of swims around a little bit, and then you have another flare and it can swell again, and it's if you keep stretching an elastic band over and over, eventually it loses that elasticity, and that's what's happening around the bones of the feet. So over time they become unstable, things move and slip, and that's why we're so keen as podiatrists and orthotists to get people to think about using footwear and insoles that support the foot, even though it might feel uncomfortable. Longer term, the evidence is starting to suggest that it does help, then it has a preventative effect in terms of deformity down the line, but it's always a balance. But essentially that's what's happening over time.
So would you recommend that people do this sort of almost right from diagnosis, so they're protecting their feet before it happens? Yeah,
absolutely. It's really important. Yeah, and we know that those 2 years after diagnosis, it seems, I mean, broadly speaking, are really critically important, because up to diagnosis we've had that period of we're in pain and we move and we carry ourselves differently, so our walking pattern changes, our joints and all those soft tissues have been strained. And then as you kind of get onto the right medications, everything settles down, we really want to work with you to retrain the way that we walk, so that you don't carry on with the walking habits that can become problematic. There's a trial in progress at the moment led by Glasgow called the GREAT trial, which is fantastic, GREAT, so have a Google of that, and it's about a new intervention to rehabilitate, so gait, the way that we walk, rehabilitation for people with early rheumatoid arthritis, specifically to look at developing this intervention. So hopefully that will help us.
I will certainly look out for that, Lindsay, because interestingly our next NRAS Live is going to be on the topic of research and how people can get involved in research. So before then, I will certainly investigate that. And you can find out about all sorts of research that's going on our website, of course. Some other links I really want to highlight is the, I just missed it now, Simply Feet. Is it Simply Feet? Yes, simplyfeet.co.uk is another really useful website for you to investigate on brands and footwear, etc., and foot health care as well. And also somebody's put in the chat that they use Flexitol Heel Balm, which contains urea, which is recommended. But I'm sure if you speak to your pharmacist, you will be able to find that and start using that cream. And as you know, getting into the habit from day one is probably the right thing to do. If anybody is watching and you're newly diagnosed with rheumatoid arthritis, do ask your rheumatology team to refer you to NRAS, to our new to RA Right Start service. And these are all the sorts of questions that you might be asking in the chat that we can cover or find you the right information and get you on the right path. So you're stepping into a future with rheumatoid arthritis in the right way. Trying to use a few little puns there, but I've made a bit of a heel of it. The other thing I'd like to share with you is we have, for those of you who might not be as familiar with NRAS, as many of you are, is our SMILE RA, which is our self-management individualized learning environment, SMILE RA. We've just launched only a few weeks ago our new module on exercise and physical activity. We know it's difficult if your feet are uncomfortable, but there's an awful lot of exercises and things you can do, seated yoga, etc., or that doesn't involve the feet as much if you've got that, but it is so important to keep moving. And also within the managing pain and flares, we refer to situations where your feet might be a problem as well. But I think the take-home message from this wonderful conversation we've had here this evening is, do raise your issues when you go into clinic. Because you're not being asked to show your feet does not mean that they don't want to hear about it. It's often because it's pressurized time, clinic time. But if feet are your real issue, do not be afraid to bring it up into the clinic time. It's your appointment. And again, there is a fantastic module on getting the best out of your consultation, whether that be a face-to-face consultation or over the phone or a video chat in some places. It's your consultation. And if it's the feet that are giving you the worst problems, then do bring it up and make sure, because as wonderful as your rheumatology nurses and consultants and registrars are, they're not mind readers. So just because they don't ask doesn't mean that you can't say. I really, really want to say a huge thank you to my guests here this evening. Thank you so much, Lindsey. There were so many more questions that we could have got through. We did 2 other foot health webinars, and they are available on our YouTube channel. You can watch all of our NRAS live broadcasts back after this. If you missed it at the beginning, or you wanted to go back and think, what did Nicola say about that, or what did Lindsey say? You can watch this back on our YouTube channel, and my colleague will put the link to our YouTube channel in the chat. So thank you very, very much for giving up your time after a busy day. Very busy day for Nicola with your 3-week-old little bundle of joy. I really, really do appreciate it. Thank you so much, Elsa, for joining us as well. And thank you, Lindsey. And I wish you all health, and I hope that you all have a wonderful summer, and join us at the last Wednesday of every month. We have one of these NRAS live broadcasts, the next one being on research, and the one after that about pregnancy and rheumatoid arthritis. So join us then. Thank you very much, and good night.
Bye, everyone.
Good night.